Okay. Good day, class. So this would be the last lesson for the finals or for their entire hematology too. We're going to talk about hematologic malignancies. Now, when we talk about malignancies, this refers to different tumors or cancer that would usually involve this tumors or cancer would involve the different cells in relation to hematology. So with that, let's start. Now, let's talk a little bit the history. Now, your hematologic malignancies would be known as your leukemia class. Now, leukemia had been reported since the time of Hippocrates. So this was before Christ era. Now, the term leukemia was coined from the word leuk, meaning white blood cells or white blood cell, and imia, meaning blood. Therefore, class, these hematologic malignancies would often affect white blood cells. Now, the condition means that there is a predominance of white blood cell in the blood, meaning there is too much or too many WBCs. Instead of having a normal value of RBCs, WBCs, platelets in a patient with leukemia, they have more they have more white blood cells in the circulation. Now, Virchow was the first to recognize leukemia as a distinct clinical disorder between 1839 and 1845. He named this disorder leukemia class because of the white appearance of the blood for patients with fever, weakness, and lymphadenopathy. In some severe cases, kasi class of leukemia, due to the increased concentration of WBC in the blood, they would be the one more predominant than red blood cell. But if you remember, the reason why we have a red blood is because there's so many red blood cells. But in a patient with leukemia, the WBCs are the ones that are the most predominant. They are so plentiful, class, to the point that they would turn blood in a creamy white appearance due to the numerous amounts of WBC. Now, leukemia's class, please take note, are neoplastic proliferative disease characterized by overproduction of immature or mature cells of various leukocyte types. So if you remember, there are a lot of leukocytes, di ba, class? We have the neutro, we have the lympho, we have the mono, the AO, and the basophil. So they are the ones affected. There would be overproduction of these WBCs, and due to the overproduction, sometimes they are more immature. Most of them are immature types. Now, lymphomas, class, take note, are similar to leukemia, but lymphomas are solid tumor localized in the lymph nodes and associated tissues or bone marrow. So if your leukemias are involving white blood cell, lymphomas are tumors itself, class, found in the lymph nodes. Now, the clinical symptom, the maturity of the affected cell line, and the total WBC count determines whether a leukemia will be classified as acute or chronic. So leukemia class is classified in 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 most times as acute or chronic, and they are based on the following: maturity of the affected cell line, the total WBC count. They are the ones used, as well as the clinical symptom. They are used to identify if the leukemia of the patient is acute or chronic. Now, after Virchow divided leukemias into two groups based on the presence of lymphadenopathy, different forms of leukemia were later classified, class, according to the affected predominant blood cell type, morphological and cytochemical result, and clinical criteria. So take note of this, class. In the current times, the classification of leukemia is based on the following. Number one, predominant blood cell type affected. Number two, its morphology. Number three is the cytochemical result. And number four is the clinical criteria. So those are the four main types used nowadays in identifying or classifying leukemia. Now, these criteria, class, are the basis of the French, sorry, Ipagsama nyo na lang to. Just combine this into a single criteria class. Cytochemical result and clinical criteria. So itong three criteria na to class, this is the basis of the FAB classification, or the French American British classification. This classification class is the one commonly used in classifying leukemia. Now, under the FAB classification, please take note that there are three. We have the myelogenous. Myelogenous, another term used here, class, is the myeloid. The myelogenous or the myeloid leukemias, the monocytic, and the lymphocytic, also known as your lymphoid classification. Now, these three you are used in the FAB classification class: the myelogenous or the myeloid, monocytic, and the last is the lymphocytic or lymphoid. Now, these three could either be further classified as acute or chronic. So your myelogenous or myeloid could become acute or chronic. Your monocytic could also be acute or chronic. Your lymphocytic or your lymphoid could also be acute or chronic. Now, take note, class, that in acute leukemias, 20% or more cells in the bone marrow are young or immature stages, while the chronic leukemias have more mature stages. So, if you find a blood picture, let's say you do a differential count, and you found a lot of, or a plenty amount of, young WBCs. Your young WBCs, if you still remember, are also known as your blasts. If you see a lot of blasts in the blood picture, when you do a differential count or a differential smear, there's a possibility that the leukemia of the patient is an acute type of leukemia. While take note, class, that chronic leukemias have more mature stages. Now, the factors related to the occurrence of leukemia are genetic, meaning, class, they could be inherited. So if you have a history of leukemia in your family, have it checked so that you would be able to identify it as early as now. Then another factor that would cause the occurrence of leukemia is immunological factor. Is your immune system functioning well or in a active state? Occupational exposure. An example of occupational exposure: are you often exposed to ultraviolet radiation? Are you exposed to different carcinogens? Similar with your environmental exposure, are you living in an area where you could be exposed to carcinogens? Chemical and drug exposure, genetic abnormalities, viral agent. If aware kayo sa different viruses class, so your viruses could cause different types of cancer. If you remember, yung human papilloma virus nyo would cause cervical. Your Epstein-Barr virus would also cause different types of cancer and also other secondary causes. When you say secondary causes, class, there is an underlying disease. So there's a primary disease. Then, due to that primary disease, you could develop cancer later on. An example, class, let's say nagkaroon ka ng TB. If you have tuberculosis, there's a possibility in the future that you could develop lung cancer. So those are secondary causes. Now, take note, another term that you need to remember here is the myeloma or the multiple myeloma. So you've already heard this in your AUBF, in your clinical chem. Now, this is a malignant proliferation of a typical and immature form of plasma cells. So if you still remember in your immunology, serology, your plasma cells are the ones that would produce antibodies. They would be the one to create your immunoglobulins. So in your multiple myeloma, you have atypical and immature plasma cell. They primarily occur in the bone marrow. Now, the exact cause of multiple myeloma is unknown, and heredity is not a factor. So take note of that, class. So this is an example of an unknown disease. So unknown yung cause of multiple myeloma. Basically, this is idiopathic, class. Now, patients' plasma is turbid because of increased levels of myeloma protein, which would cause RLU formation in their blood smear. Now, in the urine class, you will find Benz-Jones protein, which are the light chains of immunoglobulin, are demonstrable. Now, another term are the lymphomas class. So, lymphomas represent a group of malignant tumors of the lymphoid tissue, specifically the lymph nodes and the spleen. So, as mentioned earlier, your lymphomas are the tumor cell class, tumors that are found in lymph nodes and spleen, and they vary greatly in degree of malignancy and response to therapy. Now, there are two types of lymphomas: the Hodgkin's and the non-Hodgkin's lymphoma. Now, in Hodgkin lymphoma class, you would find what we call Reed-Sternberg cells. Now, these Reed-Sternberg cells class are the hallmark or their identifier. If you find Reed-Sternberg cells, automatically it's a sign that the patient has Hodgkin lymphomas. Now, this Reed-Sternberg cells class, take note, are malignant cells initially confined to the organs containing the monocytes or the phagocytes, such as the lymph nodes, spleen, liver, and bone marrow. Now, lymphomas class, if they're too many, or they're constantly malignant, they can spread. Remember, if a cancer is malignant, they're able to spread throughout the body. So if there's the lymphoma is malignant, they have this ability to spread via the bloodstream and would present a leukemic picture on the peripheral blood smear. Now, the World Health Organization classification stratifies neoplasms primarily according to cell lineage, myeloid, lymphoid, and histiocytic dendritic cells. So, another classification. Diba, earlier it was explained, we have the FAV classification. Now, the French, American, British classification. But the WHO on their own also classified leukemia based on the following: cell lineage, myeloid, lymphoid, and histiocytic dendritic cell. Now, the WHO classification, in addition to cell morphology, cytochemical reaction, and clinical criteria, would include immunophenotyping, genetic studies of peripheral blood, bone marrow, and lymph node samples. Now, let's talk about the two types, yung acute leukemias class. Now, acute leukemias are characterized by the presence of blasts or immature WBC stages in the peripheral blood and bone marrow. Now, most adult patients die of infection in short time after diagnosis. Remember, class, if a patient is infected with acute leukemias, they tend to have a shorter lifespan. Any type of disease that are usually acute would tend to be rapid and progressive. That's why if a patient is having a case of acute leukemia, they tend to have poor prognosis. Now, the leukocyte mature in a very fast phase class and so had not undergone the normal maturational stages. So if you remember, class, if in your hematology 1, anything that matures fast can lead to abnormalities. And the problem with patients with acute leukemia is that they tend to have high WBC count, but because of this high WBC count, they mature very fast class. Sobrang bilis nila mag-mature. They tend to have abnormally, or they tend to become abnormally functional WBCs. So even if a patient has leukemia with a very high WBC count, they tend to have, or they tend to be easily infected with the disease. The reason, class, is because they have abnormally functional WBC. The WBCs do not function properly. That's why even if a patient has high WBC count in a leukemic patient, they could easily be infected. due to the abnormal function of their WBCs. Now, these WBCs that matured very fast would skip generation stages, resulting to leukocytosis. Now, your acute myeloid leukemia or your acute myelogenous leukemia, your AML class, please remember, under the FAB classification, have eight types. Please remember, AML under FAB classification are eight types: MO, M1, 2, 3, 4, 5, 6, and 7. Now, MO is wherein myeloid where undifferentiated blasts are present. This is a type of AML otherwise not otherwise categorized. M1 is wherein blasts and promyelocytes would predominate. M2 is wherein myeloid. This is a type of myeloid cancer or leukemic cancer where myeloid cells demonstrate maturation beyond the blast and promyelocytic stage. M3 is wherein promyelocytes predominate in the bone marrow. M4 is myelomonocytic, where both myeloid and monocytic cells are present to the extent of at least 20% of the total leukocyte. Then in M5, monocytic, most cells are monocyte and composed of two types. We have your M5A and M5B. A, please take note class, M5A consists of large blasts seen in the bone marrow and blood, and M5B class is composed of differentiated types of monoblasts, promonocyte, and monocyte. Then your M6 class is your also known as your erythroleukemia, also known as the Guglielmo syndrome, where both erythroid and granulocytic precursors proliferate. So you'll be able to find here some rubriblasts, prorubrisite, aside from the granulocytic precursors. Then the last one is the M7, which is typically involved the megakaryocytic type. These are large and small megakaryoplasts with high nuclear cytoplasm ratio, pale and granular cytoplasm. Then we're done with the AML. So if AML class has 8 classifications under FAB, the next one is your ALL or your acute lymphoblastic acute lymphocytic leukemia. Now, see, acute lymphoblastic or lymphocytic leukemia class has 3 classifications based on FAB. We have L1, L2, and L3. Now, L1 class, please take note, is characterized by the predominance of small cells. Nuclear shape is regular with an occasional cleft. Chromatin pattern is homogeneous, meaning the chromatin pattern is smooth class, homogeneous, same sila. Nucleoli are rarely visible. Cytoplasm is moderately basophilic. Then L2 class, please take note, has large cells with an irregular nuclear shape. Cleft in the nucleus are common. So if L1, the cleft is occasional. In L2, the cleft is common. One or more large nuclei are visible. Then cytoplasm varies in color. Then in L3, Burkitt lymphoma type, cells are large and heterogeneous in size. Nuclear shape is round or oval. 1 to 3 prominent nucleoli. Cytoplasm is deeply basophilic with vacuoles often prominent. Now, another important thing when it comes to leukemia class is the use of cytochemistry. Now, cytochemistry is used as a diagnostic tool to differentiate the types of leukemia. This is based on the reaction of intracellular markers being detected in the form of lipids or enzymes, where the cells react with an added substrate in the test system. An example of a cytochem stain class is yung MPO or the myeloperoxidase and your SPB or the Sudan black B. They stain to differentiate acute myeloid AML from ALL. In the former, both stains are positive, while in the latter, both stains are negative. So take note of that. Then the esterases, alkaline phosphatase and acid phosphatase, specifically yung TRAP class or your TRAP. as well as PAS are more examples of cytochemical stains. Now, in WHO, and as well as the criteria in FAB, as well as immunophenotyping, confirms diagnosis of leukemia by identifying the types of antigen or markers on the cell surface. So if a doctor wants to diagnose or wants to identify the type of leukemia the patient has, yung oncologist class, they have to consult the WHO classification, they have to consult the FAB classification, and they need to do a immunophenotyping test. This is the most specific test to identify the type of cancer. In immunophenotyping, they're going to identify the CD markers found on the cell surface. Now, the surface markers or the CD, your cluster of differentiation, if you still remember in your immunosero, are detected using monoclonal antibodies. This is a supplementary differential testing in the various leukemias and lymphomas. Then we have your MPNs. Now, MPNs class are the myeloproliferative neoplasms. Please remember, a myeloproliferative, meaning this would tend to affect the myeloid lineage. Now, what are the myeloid lineage class? If you still remember, these are the granulocytes, these are your erythrocytes, and these are your platelets. So they would tend to include the CML. So MPNs would include the CML, chronic myeloid leukemia, polycythemia vera, primary myelofibrosis, or also known as agrogenic myeloid metaplasia, and essential thrombocythemia. So here we have WBC, here we have WBCs, RBCs, platelets. Here we have WBC, and here we have platelets. So these are the different cells affected by the MPNs. Now, there is no environmental cause of MPN that has been identified, but genetic susceptibility class may exist. So you could acquire this, or it could be inherited. Then we have your myelodysplastic syndromes, also known as your pre-leukemia and myelodysplastic or myeloproliferative neoplasm. So they are similar in characteristic. Now take note, class, that this MDS, itong myelodysplastic syndrome, are characterized by simultaneous proliferation and apoptosis. Apoptosis referring to programmed cell death of hematopoietic cell, leading to a normal or hypercellular marrow biopsy and peripheral blood cytopenia. And this could lead to a low cell count class, wherein anemia, thrombocytopenia, and leukemia are common. So in MDS class, just for you to understand this, there is an increased cell count. All three class, RBC, WBC, and the platelet. But what happens here is that the body, the bone marrow, would react to this cell count, and the cells here would die at a very fast rate due to apoptosis. Due to apoptosis. So here you would have high amounts of or high creations of RBC, WBC platelet, but at the same time, class, they would die also via apoptosis immediately. And because of this death, they could lead to anemia, thrombocytopenia, and leukopenia. Anemia, low RBC, if you have no idea, low platelet for thrombocytopenia, and leukopenia, low WBC. Now, your MDS are classified into refractory anemia, RA, RARS, refractory anemia with ring sideroblasts, RAEB1 and 2, or your refractory anemia with excess blasts, the first to demonstrate an overt class relationship to AML. So RAB 1 and 2 class are related to AML. Now, the myelodysplastic and myeloproliferative neoplasm is composed of chronic myelomonocytic leukemia, your CMML, characterized by feature of both an MPN and MDS. Now, CMML consists of two types, CMML1 and 2. Now, general peripheral blood smear would demonstrate a persistent monocyte count. This is the hallmark of CMML, greater than 1 times 10 raised to the 9 per liter. MDS patients class transformation to AML can happen. MDS and AML patients share certain specific karyotypes. So see MDS class. As mentioned in the previous slide, this is a type of pre-leukemia stage. Now, if at left untreated, if left to continuously develop, this can lead to AML itself. And in some cases, this could also become CML. In the types here, yung CMML1 nyo, they tend to show a monocyte count greater than 1 times 10 raised to the 9 per liter. So these are the different characteristics, cell type, and site of malignant cell. So for leukemia's class, please take note. Overproduction of various types of immature or mature WBC. That's their basic characteristic. Pag lymphoma class, as I mentioned earlier, solid tumor in the lymph nodes. Pag myelomas naman class, plasma cells are overproduced. Then for the cell types, leukemia, the usual cell type are the leukocytes of the myeloid or lymphocytic cell line. For the lymphomas, lymphocyte class is the distinctive cell type. Presence of the so-called Reed-Sternberg cell. Then for the myeloma, as mentioned, they would be involving plasma cell. For the site of malignant cell, leukemias are usually found they could be all found in the circulation, even the blood-brain barrier. Lymphomas class naman are usually confined to the organs containing phagocytes such as the lymph nodes, the spleen, the liver, and the bone marrow. For the myelomas, they tend to form a mass or tumor located in the bone marrow. Now let's discuss the two types of, or the two forms of leukemia, the acute and the chronic. So let's start with their definition first. So acute leukemia class would tend to have symptoms of short duration. Many immature WBCs form in the bone marrow or peripheral blood smear. Elevated total WBC count. Then we also have your chronic leukemia, symptoms of longer duration. Mostly mature cell forms are found in the bone marrow or peripheral blood. Total leukocyte counts would range from extremely elevated to lower than normal. So take note of their difference class. If it's acute leukemia, shorter duration, many immature WBCs, elevated total leukocyte count. Then for chronic leukemia, longer duration, mostly mature cells, and total leukocytes are extremely elevated. Then we also have your lymphomas and myelomas. So lymphomas class is a general term for malignancy that starts in the lymphoid system, mainly in the lymph nodes. There are two types, the Hodgkin and the non-Hodgkin. So again, class, if it's the Hodgkin lymphoma, there is a proliferation of malignant WBC, which have a basophilic vacuolated cytoplasm with a starry sky pattern due to numerous tangible body macrophage that are arrested at certain stages of maturation. Hallmark again is the Reed-Sternberg cell, which would appear as a large binucleated or multinucleated cell resembling an owl's eye appearance, with each nucleus bearing a very large nucleolus. Then we have the non-Hodgkin lymphoma. This is characterized by a diffuse large B-cell lymphoma. Reed-Sternberg class is absent, but mixed population of lymphocyte, histiocyte, eosinophils, and some plasma cells are present. Then we have your myeloma, which again is the cancer of the plasma cell. Overgrown there's too much plasma cell here. So plasma cell overgrows, forming a mass or tumor located in the bone marrow. Now let's go to the classification class of leukemias, lymphomas, and myelomas and their laboratory profile. Let's start with the FAV classification class. So the FAV classification would separate your leukemia into three groups: the myelogenous, the monocytic, the lymphocytic. Now, major types of leukocytic leukemias can be classified as acute or chronic. So this is what I was mentioning earlier, class. FAB would classify it into three types: myelogenous, monocytic, lymphocytic. Then they would be further classified as acute or chronic. So examples of this is acute or chronic myelogenous leukemia, acute or chronic monocytic leukemia, acute or chronic myelomonocytic leukemia, acute or chronic lymphocytic leukemia. While WHO classification class is based on morphology but combine this information with the following: immunophenotyping, genetic studies of peripheral blood, bone marrow, and lymph node samples. Now let's go with the acute leukemias class. So acute myeloid leukemia class, please take note, must be distinguished from acute lymphoblastic leukemia, as well as myelodysplastic syndrome or AML arising in the presence of myelodysplastic syndrome, because therapeutic strategies and the prognosis would vary considerably for this disease. So it's very important, class, that we would be able to differentiate AML from ALL, from MDS, and from AML due to MDS. The reason is because they have different treatment strategies. Now, acute leukemias are characterized by the presence of blasts and immature WBC. Anemia is also present. Now, this can be caused, yung anemia nyo, class. Anemia could be caused by bleeding and replacement of normal marrow elements by leukemic blasts. So instead of having RBCs in the young RBCs in the bone marrow, they tend to be replaced by blasts, causing anemia, class. Now, total WBC count is usually elevated. Some patients may demonstrate normal or decrease WBC count. Now, AML, class, remains a lethal disorder which kills the majority of afflicted adults. Now, there are two major divisions here: AML and your ALL. Again, there are 8 classifications based on FAB for AML: MO to M7. For ALL, there are 3: L1 to L3. Now, let's start with the explanation on, sige, this one. So again, class, FAB classification. So let me just explain this again, class, for the third time. So FAB classification is based on the morphological characteristic of bright stained cells in the peripheral blood or bone marrow and cytochemical staining of blasts. So if it's FAB classification, class, based on peripheral blood smear, cytochemical stain result. Now, the system is based on the type of cell from which the leukemia developed and the maturity of cells. Classification are based largely on how the leukemia cells would look under the microscope after routine staining. Now, in a revision of the original criteria, more than 30% of blasts in the marrow suffice for the diagnosis of acute leukemia in any of the categories. Then for the WHO classification, this is based on morphology, cytochem, immunophenotype, genetics, clinical picture. So between the two class, mas detailed ang WHO, but mas ideal pa rin ang FAB because you would use conventional techniques here, such as the right stain, yung paggawa ng peripheral blood smear. Now let's go with the AML. So general characteristics of AML. This is the most common leukemia subtype, recognized as a heterogeneous clonal disorder. Characterized, class, by the following: maturation block and accumulation of acquired somatic genetic alteration in hematopoietic progenitor cells that alter normal mechanism of self-renewal, proliferation, and differentiation. So just to explain this, class, this means that the progenitor cell in the myeloid line has genetic abnormalities. Now, these genetic abnormalities would include the following. The first one The first one is the FL3 gene abnormality. Now, the FL3 gene would usually encode a type 3 receptor tyrosine kinase, also known as your FL3 tyrosine kinase. Now, si FL3 tyrosine kinase nyo class is involved in leucomogenesis by a number of different genetic mechanisms. Now, FL3 is known to be mutated up to 30% of patients with AML. So that's one genetic abnormality in the progenitor cell. Another genetic abnormality is the CBF complex, or the core binding factor complex. Excuse me. Now, the CBF class is a transcription factor complex critical for regulation of hematopoiesis and normal myeloid development. Now, the following would affect CBF complex: translocation of chromosome 821, Q22, Q22, or inverse 16, P13Q22, translocation 1616, P13Q22, leading to AML subgroups with favorable prognosis. And the last genetic abnormality is the microRNA, associated with cytogenetics, molecular and morphological alteration, and clinical outcomes in AML, capable of distinguishing between different leukemias. So let's start with the first FAV classification, the MO. The MO. Now, this is acute myeloid leukemia minimally differentiated. So it's known as AML minimally differentiated, characterized by the presence of undifferentiated blasts. This is a type of AML not otherwise categorized. WHO classification of AML not otherwise categorized. So yun yung tawag sa kanya class. AML not otherwise categorized. Now, M1 class, these are blasts and promyelocytes would predominate without further maturation of myeloid cell. WHO synonym for this condition is your acute myeloblastic leukemia without maturation. So M1 is known as your acute myeloblastic leukemia without maturation. Now, the clinical signs and symptoms class would include a rapid or gradual onset resembling an acute infection. Tumor masses has presence of large quantities of the enzyme. If tested with the cytochemical myeloperoxidase, it produces a green appearance if the tissue is cut. This type of tumor is referred to as a chloroma. So in M1 class, it can lead to the formation of a chloroma. The appearance of this tumor is an early sign of AML. Lab presentation class is anemia and thrombocytopenia in 85% of all AMLs. Leukocytosis is encountered in more than one-third of patients. A granular or hypogranular segmented neutrophils may also be seen in acquired Pelger-Hewitt anomaly. Abnormal eosinophils may also be seen. Monocytes would usually constitute less than 1% of the nucleated cells in the peripheral blood. Now let's continue with M2 class. So the M2 is a myeloid cell which would demonstrate maturation beyond the blast stage and promyelocyte stage. Now the synonym for this disease is M2 for WHO is acute myeloblastic leukemia with maturation. Now, the clinical sign of M2 or AML with maturation class would follow hemorrhagic manifestations such as easy bruising, epistaxis, gingival bleeding, and petechiae. Hepatomegaly, splenomegaly, and lymphadenopathy are seen infrequently. Lab presentation would include anemia and thrombocytopenia. Leukocytosis is commonly seen, with rare patients having a WBC count exceeding 300 times 10 raised to the 9th per liter class. Myeloblasts would predominate on peripheral blood smears. Our rods are commonly seen. Take note of this class. For M2, our rods are seen. Maturation of the granulocytic line is also observed. Then we have the M3. Now, the M3 is wherein promyelocytes would predominate in the bone marrow. Synonym here for the WHO classification is the acute promyelocytic leukemia. Clinical signs and symptoms would include fatigue and symptoms of bleeding such as bruising, hematuria, and petechiae. Hepatomegaly, splenomegaly, and lymphadenopathy are also seen infrequently. M3 appears to be the most aggressive class of acute leukemia, with a severe bleeding tendency and a fatal course if untreated of only weeks. Lab presentation would include anemia and thrombocytopenia, total leukocyte count ranging from conditions of leukopenia to leukocytosis. Leukopenia is seen frequently. Promyelocytes are the predominating cell type. Then we have the M4, the myelomonocytic. Here, class, both myeloid and monocytic cells are present to the extent of at least 20% of the total WBC. This is referred to as the Naegeli type monocytic leukemia. WHO name class is the acute myelomonocytic leukemia. So here, in this type of leukemia class AML M4, they tend to have hyperleukocytosis and are at the risk of leukostasis development. When you say leukostasis development, this refers to a pathological finding of slightly dilated thin-walled vessels filled with leukomic cells. The brains and lungs are the most commonly involved organs. So here you would find your thin-walled blood vessels, your capillaries, filled with WBCs. Now the lab presentation here are proliferation of granulocytes and monocyte is characteristic. Anemia and thrombocytopenia are present. Total WBC varies from leukopenia to leukocytosis. Total leukocyte count rarely exceeds 100 times 10 raised to the 9 per liter. The absolute monocyte count reaches or exceeds 5 times 10 raised to the 9 per liter in many patients. The absolute monocyte count reaches or exceeds 5 times 10 raised to the 9 per liter in the peripheral blood. Then we have your M5. This is the monocytic series. Most cells are monocytic. Then they could be characterized into M5A and M5B. Now, if it's M5A class, characterized by large blasts in the bone marrow, excuse me, and even the peripheral blood, common in young adults. While M5B class is differentiated by monoblasts, promonocyte, and monocytes, common during the Middle Age. Now, this is referred to as the Schilling's type. Take note, class. M5B is known as the Schilling's type. Now, the classification of M5A is known as your acute monoblastic leukemia, while M5B is known as your acute monocytic leukemia. Again, if it's M5A, monoblastic, plastic. Pag M5B class, it's monocytic leukemia. Now, the clinical sign and symptoms is dramatic class, with headaches and fevers being the chief complaint. Typical symptoms of monocytic leukemia would include fatigue, weight loss, and bleeding from the mouth or nose. Lab presentation is anemia, thrombocytopenia, and the total leukocyte count ranges from 15 to 100 times 10 raised to the ninth per liter. Peripheral blood smears would normally exhibit a high proportion of blast form. Monocyte and promonocytes constitutes 25 to 75% of the nucleated cells. Then we have your M6 class, your erythroleukemia. This is also known as your erythmic myelosis or the Guglielmo syndrome. This is characterized class by the abnormal proliferation of both erythroid and granulocytic precursor, and may even include abnormal megakaryocytic and monocytic proliferation. WHO synonym for M5, M6A, and M6B is known as your acute erythroid leukemia. Clinical symptoms class would include a bleeding manifestation. Hepatomegaly, splenomegaly, and lymphadenopathy are infrequently observed. Lab presentation: blast cells of erythroid and myeloid origin are found in both the bone marrow and the peripheral blood. Erythroblasts on blood smears would typically have an irregular outline with a high nuclear cytoplasmic ratio. Blasts of myeloid origin may have hour rods. Promyelocytes may also be present, as well as monocytes and promonocytes. Then the last classification class, the last one, the M7 or the megakaryocytic. So characterized by the presence of large and small megakaryoplasts with a high nuclear cytoplasm ratio, pale agranular cytoplasm. Its WHO name is acute megakardioblastic leukemia. So clinical signs and symptoms would include organomegaly, which is infrequent except in children. Radiographic evidence of the bone-lytic lesions have been observed in children as well. Lab presentation class cytopenia is usually present, particularly thrombocytopenia. Immunophenotyping reveals that megakardioblasts express one or more of the platelet glycoproteins, CD41 or CD61. Blasts are negative with anti-MPO antibody. So we're done with the FAB classification class from MO to M8. Now we have the WHO classification. So there are three. Let's start with the first one, the acute myeloid leukemia with certain genetic abnormalities. So we have AML with translocation 821, AML with inversion 16 or translocation 1616, AML with translocation chromosome 911, APL with translocation 1517. So those are the WHO AML with certain genetic abnormalities. So this is the second. The second type class is acute myeloid leukemia, not otherwise specified. So we have AML with minimal differentiation, AML without maturation, AML with AML with maturation, acute myelomonocytic leukemia, acute monoblastic monocytic leukemia, acute erythroid leukemia, acute megakardioblastic leukemia, and acute basophilic leukemia. And then the last group is the acute leukemias of ambiguous lineage. We have acute undifferentiated leukemia, mixed phenotype acute leukemia with translocation 922, mixed phenotype acute leukemia with translocation V11Q23, mixed phenotype acute leukemia, B lymphocyte myeloid cells, and mixed phenotype acute leukemia. Now let's go to the acute lymphoblastic leukemia. So we're done with the AML class. Now let's go to the ALL. Now ALL is the most common cancer in children class, representing 23% of cancer diagnosis among children younger than 15 years of age. So we have L1 to L3. L1 is common on children, L2 older children and adults, and L3 is patients with leukemia secondary to Burkitt's lymphoma. Now differentiated based on morphology including cell size, prominence of nucleoli, amount and appearance of cytoplasm. Now it is generally accepted class that T-cell acute lymphoblastic leukemia or your TALL results from the malignant transformation of normal developing T cells in the thymus, the so-called thymocytes. So si TALL nyo class is due to the abnormality in the thymus, yung pre-T cells nyo. Now, the general characteristics of ALL class, the WHO classification that is synonymous with FAB1, L1, and L2 is, so if L1 and L2 class is the FAB classification, it also has a name under WHO. L1 and L2 is known in WHO as precursor B lymphoblastic leukemia or lymphoblastic lymphoma, also known as the precursor B cell ALL. Now, this is a neoplasm of lymphoblasts committed to the B cell lineage. while the precursor T lymphoblastic leukemia. So this is L1 class. Yung L2 nyo naman is the precursor T lymphoblastic leukemia, lymphoblastic lymphoma, neoplasm of lymphoblasts committed to the cell lineage. So itong L1 nyo, ang WHO synonym niya, the synonym WHO synonym is the precursor B lymphoblastic leukemia. L2 naman is the precursor T lymphoblastic leukemia. Just remember here that if you still remember in your immunosero, your lymphocytes would either become in the future a T cell or a B cell. So L1 would usually affect B cells, L2 would usually affect T cells. So this is the summary class of the ALL. So for the size of the blast, L1 is small, L2 is large, heterogeneous, L3 is large. Nuclear shape, L1 is indistinct, L2 is indented or prominent, L3 is regular, oval to round, and for the nucleoli, L1 is scant, L2 is large and abundant, L3 is prominent and vasophilic. While for the cytoplasm, L1 is invisible, L2 is moderately clefted, and L3 has prominent vacuoles. Now let's start with the explanation on each type. So L1 is also known as homogeneous. The reason why it's homogeneous, it only has one population of cells. Small cells would be predominant. Nuclear shape is regular with an occasional cleft. Chromatin pattern is homogeneous and nucleoli are rarely visible. Cytoplasm is moderately basophilic. While L2 class are heterogeneous, so these are large cells with an irregular nuclear shape. Clefts in the nucleus are common. So take note of that. Clefts are common in the nucleus. One or more large nucleoli are visible. Cytoplasm varies in color. Then L3 is also known as the Burkitt lymphoma type. Cells are large and homogeneous in size. Nuclear shape is round or oval. 1 to 3 prominent nucleoli. Cytoplasm is deeply vasophilic with vacuoles often prominent. Continue class with the clinical signs and symptoms of ALL. So all of your acute lymphoblastic leukemia have similar signs and symptoms. So L1 to L3 class have similar signs and symptoms. Now they vary from few days up to few weeks. Now it would usually begin pain in the extremities, such as the legs, produced by an infiltration of leukemic cells into the tissue. Lymphadenopathy, hepatomegaly are present in 75% of patients. Leukemic meningitis and cranial nerve palsy is caused by nerve infiltration by leukemic blasts are quite common. Leukemic cells can infiltrate many areas of the body. Now, the lab presentation, there would be a total leukocyte count that is elevated in 60 to 70% of patients, ranging from 50 to 100 times 10 raised to the 9 per liter. So, just a recap class, your normal WBC count is usually 5 to 10 times 10 raised to the 9 per liter. Here, it would rise 50 to 100. Then, less than 15% of patients would exhibit extreme leukocytosis. Total leukocyte would usually be greater than 100 times 10 raised to the 9 per liter. Approximately 25% of patients would exhibit leukocytopenia. Then, peripheral blood smear would show predominance of blast cell, close to 100% lymphoblasts, lymphocytes, and the characteristic smudge cells. Now let's go with the chronic leukemias class. So we're done with the acute leukemias. Now let's go with the chronic leukemias. Now this is characterized by the presence of leukocytosis with an increased number of mature lymphocytes, lymphocytosis on a peripheral blood film. Example would be malignant lymphoproliferative disorder, characterized by an accumulation of lymphocytes. So WHO classification would include the following acute leukemias. We have the most common, yung CLL, the chronic lymphocytic leukemia, also known as the small lymphocytic lymphoma. Then we have your B cell prolymphocytic leukemia, hairy cell leukemia, and the plasma cell neoplasm. So these are the four chronic leukemias class. Now let's start with the CLL and the SLL, or the chronic lymphocytic leukemia. Now this is the most common form of leukemia in adults class in Western countries, but very rare in the far Eastern countries. Neoplasms are composed of small B cells in the peripheral blood, bone marrow, spleen, and lymph nodes, mixed with pro-lymphocyte and para-immunoblasts, forming proliferation centers in tissue infiltrate. It accounts for almost 7% class of non-Hodgkin lymphomas in biopsy. The median range of onset is 65 years old. So usually it would affect geriatric patients class aging 65 years old and above. This form of leukemia is rare before age 20 and uncommon before age 50. Classic CLL is usually a B cell disorder. So take note of that class. The classic CLL is a type of B cell disorder, meaning it would affect B cells, the B lymphocytes. BCLL is a biologically and clinically heterogeneous hematologic malignancy. So when you say heterogeneous, it affects a lot of cell lines, characterized by a gradual progressive accumulation of morphologically mature B cells in the blood, bone marrow, and lymphatic tissues. The cells are characterized as CD5 positive, CD19 positive, and CD23 monoclonal B cells. Let's continue with the causes of the CLL class and the SLL. So these are usually caused by chromosomal alterations. So this is a genetic problem seen in 13q deletion, 11q deletion, trisomy of chromosome 12, most consistent finding which is present in approximately 50% of patients. So ang trisomy of chromosome 12 class is common in CLL, seen in 50 patients. Then we have 17p deletion, translocation of chromosomes 8 and 14 associated with BCLL. So take note of this class. Translocation of chromosomes 8 and 14 is associated with BCLL. Translocation of chromosome 9 and 22 is observed in non-T and B types. So take note of that. B cells would display the classic surface immunoglobulin markers: CD19, CD20, 24, and CD5. Now, the signs and symptoms class of CLL would include abnormal findings on CBC. Symptoms would include malaise, low-grade fever, and night sweats. Hepatosplenomegaly class is also frequently present. Lab presentation class total WBC would range from 30 to 100 times 10 raised to the 9 per liter. One-third of patients would show a WBC count class greater than 100 times 10 per liter. Absolute lymphocytosis is a usual finding. Peripheral blood smear would exhibit up to 80% or 90% small lymphocytes. Serum electrophoresis studies would usually show hypogamma globulinemia. Or you would tend to have, if you remember sa electrophoresis nyo, they would separate proteins. So yung gamma globulins would show low level in serum electrophoresis. Now let's go to the second type of chronic leukemia, the hairy cell leukemia. So this is an uncommon chronic lymphoproliferative disorder of the B cell type, more common in males class than in females. Suggested that a locus on the X chromosome might be involved in hairy cell leukemia. The reason why hairy cell leukemia is named class because of the appearance of a fine hair-like irregular cytoplasmic projections found in the lymphocytes. So the lymphocytes class here would have fine hair-like projections. The cytochemical feature of hairy cell leukemia would include a strong acid phosphatase reaction that is not inhibited by tartric acid. So this is a tartrate-resistant acid phosphatase stain. TRAP positive siya class. It's TRAP positive. And it could vary with disease progression. Following interferon therapy, enzyme activity in the hair cell may lead to TRAP negative. Immunological markers would include CD9 positive, CD20, CD22, 24, and 25. Reactivity to monoclonal antibody recognizing interleukin or the TAC receptor, interleukin 2 TAC receptor. In addition, the cells would display strong immunoglobulin. Then clinical signs and symptoms class would include abnormals in CBC. There would also be malaise, low-grade fever, night sweats. Frequently present ang hepatosplenomegaly. Total leukocyte count would range from 30 to 200 times 10 raised to the 9 per liter. In one-third of patients, WBC count is greater than 100. Absolute lymphocytosis is a usual finding. Exhibits 80 to 90% of small lymphocytes. Electrophoresis would usually show hypogammaglobulinemia. Then hairy cell leukemia variant class is more aggressive type of HCL. So there is a classical HCL class, but at the same time there is a variant. Now this variant, take note, is more aggressive than your classical HCL. And in the variant hairy cell leukemia, cells are smaller with a central round nucleus, a prominent nucleoli, a larger nuclear cytoplasmic ratio, basophilic cytoplasm with occasional cytoplasmic projection. Now, differential between the variant from the classical or the typical HCL can be made by cytochemical staining and immunophenotyping. Take note, class, that the variant HCL has poor prognosis, meaning treatment outcomes are usually failed. There is a very high chance for the treatment outcome to fail. Now let's go to the third one, the prolymphocytic leukemia. This is malignancy of B prolymphocytes affecting the blood, bone marrow, and spleen, characterized by a large number of small lymphocytes with scant cytoplasm. Leukocytosis can exceed 100 times 10 raised to 9 per liter. Prolymphocytes must exceed 55% of lymphoid cells in the peripheral blood. Immunological markers would include CD19 positive, CD20 positive, CD24 positive, CD22 positive. Cells would display strong immunoglobulin. Then we have the last one, the multiple myeloma or the plasma cell myeloma. So this is a malignant bone marrow-based plasma cell neoplasm associated with abnormal protein production. Plasma cell leukemia is an increased number of plasma cells in the peripheral blood and should be considered a form of multiple myeloma and not a separate entity. Usually evolves from a symptomatic premalignant stage of clonal plasma cell called monoclonal gammopathy, an undetermined significance. The onset of disorder is between the ages of 40 and 70 years old, with a peak incidence in the seventh decade of life. So common siya among elderly talaga, 40 to 70. Then symptoms would include bone pain, weakness, fatigue. Abnormal bleeding would also occur, and in some cases, class, there would be acute infection, renal insufficiency, hypercalcemia, or amyloidosis. 90% of patients would suffer from broadly disseminated destruction of the skeleton. Multiple myeloma leads to a compensatory decrease in synthesis and increase in catabolism of normal immunoglobulin. Granulocytopenia may develop as a result of bone marrow failure. Lab presentation class, please take note, would include increased plasma volume, usually caused by the increased monoclonal protein, leading to hypervolemia. So in this case, class, you tend to have higher amounts of plasma proteins. Relative lymphocytosis is usually present. Rouleau formation on the peripheral blood smear is common. Bleeding class is also common. Now, bleeding is common class because of platelet abnormalities, abnormal aggregation of platelets, and interference with platelet function by the monoclonal protein. Then this can also be caused by inhibitors of coagulation factor and low levels of platelets known as thrombocytopenia due to the plasma cell uh, infiltrating the bone marrow. So instead of having platelets created, yung mga megakaryoblast nyo, they are being replaced by these plasma cells. Then electrophoresis of serum usually demonstrates the overproduction of IgM or yung 19S antibodies. The monoclonal serum protein is detected in 91% of patients. The type of antibody is IgG in the majority of patients. Less frequently, IgA is seen, and rarely IgD is demonstrated. Now let's go to the lymphomas class. So lymphomas are lymphoproliferative disorders. Includes the various forms of leukemia and malignant lymphomas that are of lymphoreticular origin. Now, lymphomas class are group of related disorder characterized by the overproliferation of one or more cell types of the lymphoid system, such as the lymphoreticular stem cell, lymphocytes, reticulum cells, and histiocytes. So if you still remember class, the lymphomas are usually tumors in the lymph nodes, the spleens, caused by the proliferation of these cells. Now, they are classified by the real classification. Real classification stands for Revised European American Lymphoma Classification and the WHO classification of tumors of the hematopoietic and lymphoid tissue. Now they classify lymphomas into two types, Hodgkin's and non-Hodgkin. Again, class, if it's Hodgkin lymphoma, there's the presence of the Reed-Sternberg cell, while the non-Hodgkin lymphomas have no Reed-Sternberg cells. So let's discuss them in a more better explanation. So the Hodgkin disease or the Hodgkin lymphoma is characterized by the presence of Reed-Sternberg cell. They function as stimulatory cells in many lymphocyte reaction. They are considered accessory cells in mitogen-induced T cell proliferation. Antigen-presenting cells in HLA-D are restricted. Antigen-specific T cell activation, characterized by a persistent defect in the cellular immunity with abnormalities in T cells, interleukin 2 production, and increased sensitivity to suppressor monocytes and normal T suppressor cells. Aneuploidy, or the deviation from the diploid number of chromosomes resulting from the gain or loss of chromosomes or from polyploids, is a characteristic feature of Hodgkin disease. A gain of chromosome 1, 2, 5, 12, and 21 is a recurring numerical abnormality. So in Hodgkin disease class, take note that there's a problem with certain chromosomes 1, 2, 5, 12, and 21. There could be the destruction of these chromosomes or rearrangements, especially chromosome 1, which is frequently observed. While the non-Hodgkin lymphoma class is the most frequent type of non-Hodgkin lymphoma, is the diffuse large B-cell lymphoma. So take note of this class. Diffuse large B-cell lymphoma is the most frequent type of non-Hodgkin. Now, there are three different types of diffuse large B-cell lymphoma that is based on gene expression subgroup. We have the germinal center, B-cell-like lymphoma that expresses high levels of genes characteristic of germinal center, B-cell-like limal germinal B-center B cells. Activated B-cell-like lymphoma, which expresses genes characteristic of mitogenetically activated B cell. New subgroup type 3 diffuse large B-cell lymphoma, which has a heterogeneous gene expression, suggesting it includes more than one subtype of lymphoma. Now, another type of non-Hodgkin is the Sézary syndrome. So this is a leukemic phase of cutaneous T-cell lymphoma and mycosis fungoides. So it occurs when you have a possible infection of the T cell class, characterized by the presence of abnormal circulating lymphocyte and the presence of what we call Sézary cells. Now, itong Sézary cells na to class is that typically the size of a small lymphocyte and has a dark staining clump nuclear chromatin pattern. Mature T cell and NK cell neoplasms are derived from mature or post-thymic T cells. Then we have the CML class. So CML class is very rare among the chronic myeloid leukemia. Mas common talaga ang CLL. Now, CML class is associated with the BCR-ABL1 fusion gene located in the Philadelphia chromosome, the PH1 chromosome. This is translocation of DNA between chromosome 9 and 22. So, nagkaroon ng translocation class between chromosome 9 and 22. So, take note of that. This is the BCR-ABL fusion. Yun ang cause ng CML, the Philadelphia chromosome. Now, we have another one, itong polycythemia vera. So this is the myeloid line na. The second one under the myeloid line is the polycythemia vera. So this is first discovered by William Osler. He named it polycythemia rubra vera. Clinical description is wherein a patient with engorged veins, so malalaki yung veins nila, plethora, and an elevated RBC count. So all of the cell lines are elevated. Leukocytosis and thrombocythemia were recognized as additional features. Now, in 1951, Dame-Sheck added polycythemia vera to the classification of MPNs. Main differential diagnosis is that of a reactive erythrocytosis due to hypoxia. Clonal stem cell disorder is characterized by hyperproliferation of erythroid, myeloid, and megakaryocytic lineages. So your RBC, WBC, and platelets are increased. Then modern blood analysis showed that polycythemia vera 1 is highly expressed in normal human bone marrow and to a much lesser degree in fetal liver. Now, take note of the signs and symptoms. Plethora is a hallmark of PV. Pag sinabi yung plethora class, you have increased RBC, increased WBC, increased platelet count. Increase in total blood volume is also seen. Most serious complication would be arterial and venous complication. Transition and could transition to acute leukemia. Thrombophlebitis with pulmonary embolism class is also a common complication of PV and often is unrecognized. So in this situation class, due to the high amounts of cell counts in your blood, they tend to block the pulmonary artery, leading to this embolism, which can cause difficulty in breathing to patients. Now, in some cases, it could even lead to death. Now, lab presentation would show increased RBC count, increased hematocrit or packed cell volume, increased hemoglobin. Normal indices, yung MCV nyo, MCH, and your MCHC. Now, decreased serum erythropoietin is also seen. Peak polycythemic values would show a hemoglobin of 20.6 gram per DL, hematocrit of 80%, total WBC count of 28,000 times 10 raised to the 9 per liter, platelet count of 1,400 times 10 raised to the 9 per liter. Then we have the another under the myeloid line, we have the primary myelofibrosis. So this is characterized by systemic bone marrow fibrosis and extramedullary hematopoiesis. While the secondary myelofibrosis is infiltrative disorder, including malignancy and infection or exposure to chemical toxins or irradiation. So to diagnose primary myelofibrosis class, there are two criteria to consider, the major and the minor. Now, for the major criteria, it should show megakaryocytic proliferation with abnormal morphology, usually accompanied by reticulin or collagen fibrosis, not meeting the criteria for other MPNs. Evidence of JAK2 V617F or other related mutation. For the minor criteria, it would show leukoerythroblastosis, anemia, increased LDH, and increased spleen size or splenomegaly. Then we have your essential thrombocytosis or essential thrombocythemia, characterized by significant increase in circulating platelet, usually in excess of 1,000 times 10 raised to the 9 per liter. Elevated platelet counts may be encountered as a reactive phenomenon, secondary to a variety of systemic conditions, or they may represent essential thrombocythemia, a primary disorder of the bone marrow. So it would show persistent elevation of platelets in the peripheral blood, significant increase of megakaryocytes in the bone marrow. Again, this also not meet the criteria of other MPN. Demonstration of JAK2 V617F or related mutation, or in the absence of JAK2 V617F, no evidence for reactive thrombocytosis. Then we have the myelodysplastic syndromes and neoplasm. So the MDS class. So MDS would include RA, the RARS, and the REB1 and 2. So these are usually refractory anemia class associated that could lead to acute leukemias. So this is the classification. So I want you to memorize them. They would include the different subtypes. Then it would show the peripheral blood monocyte, the ring sideroblast, the peripheral blood, the bone marrow, and our bodies in the bone marrow. So take note that RABT is the only one with a possible our bodies in the bone marrow. Then the greatest percentage of blood cells could be found in RABT as well, as 20 to 30%. Now CMML would show greater than 1,000 monocytes. So kindly memorize this table, class. Also, this is the classifications also of MDS with the peripheral blood and the bone marrow difference. So kindly memorize them. They will definitely come out in your coming quiz and exams. Now let's go to the CMML. So there's also the classification on the peripheral blood and the bone marrow. So on CMML1, the bone marrow would show less than 10%. CMML2 would also show presence of our rods in the bone marrow. So memorize this table, class, as well. Now let's go to the CMML1, other classifications of CMML. We have the first one, the atypical chronic myeloid leukemia, or the BCR-ABL1 negative. It exhibits features of both myelodysplastic and myeloproliferative disorders, characterized by leukocytosis with the majority of neutrophil. Multilineage dysplasia is common. Then we have the juvenile myelomonocytic leukemia, disorder of childhood, proliferation of granulocytic and monocytic lineages. Blasts and promonocytes account for less than 20% of peripheral blood cell and bone marrow aspirates. Erythroid and megakaryocytic abnormalities are frequently present. BCR-ABL1 mutation is absent, but mutation of genes of the RAS MAPK pathway are characteristic. Then we have the myelodysplastic myeloproliferative neoplasm, unclassifiable. This meets the definition of MDS and MPN class, but does not meet the criteria for CML, MML, or other classification in this category. Now let's go to the last topic, the cytochemical stains, which are important in diagnosis for leukemia. We have the MPO, or the myeloperoxidase. Differentiate AML from ALL. AML is positive class, negative for ALL. Take note that when using the substance, the MPO, it should be fresh because enzymes are unstable. Marker for our rods due to primary granules. Positive color or positive result class of my MPO is a black precipitate or reddish brown termed as 5 bodies. Then Sudan Black B, differentiate AML to ALL as well. Again, AML is positive. Stain lipids and phospholipids. Air dry and fresh can both be used. Positive color is a black color. Then we have your chloroacetate, or the naphtol AST. Stains granulocytic lineage. This is also known as your specific esterase, used to differentiate granulocytic leukemia from monocytic leukemia that produces red granules if positive. Then we have the non-specific esterase. So itong chloroacetate esterase is known as the specific esterase. But the non-specific esterase is divided into two. We have the ANAE and the ANBE. Now, A and AE would usually be used for monocytes, plasma cell, and megakaryocyte. Positive result is red brown. Addition of sodium chloride is used to inhibit monocytic series, while the A and BE is specific for the monocytic series only. Positive for dark red precipitate. Then we have your PAS, your periodic acid shift, stains most carbohydrate in all red cell except pronormoblasts, useful for AML, M6, or erythroleukemia. Positive color is magenta or purple. Basophils, lymphocytic series, plasma cells, and erythrocytic cell series. Then we have your ACP stain or your acid phosphatase stain. Stains ACP found in lysosomes in myelocytic lineage and lymphocytic lineage. Tartric acid may be used to identify hairy cell leukemia, which is resistant to L-tartrate. Heparin must be used. Positive result is purple to red granules. Then we have your TDT, can stain all due to polymerase immunoperoxidase to differentiate ALL to AML. Then the last stain is the toluidine blue or the metachromatic stain. Stains acid mucopolysaccharide of mast cells and basophils. So this table class shows the summary of the reaction of your cytochemical stain to all the AML FAV classifications. So kindly memorize the table class. They would definitely come out. But to give you a quick examination, M4 is positive to all except for the factor 8. So I want you all to memorize this. This will come out in your coming quiz and assessment. So that ends the hematologic malignancies and diagnosis. Thank you.